You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 7th, 2020. This week, a New England Journal of Medicine retraction, TAVR, ICDs, long QT syndrome, and screening. First, I want to start with a correction. On the last podcast, I mistakenly said the Improve It trial, which was simvastatin ezetimibe, when I meant Reduce It, which is icosapent ethyl. Sorry for that, and thanks to the many listeners who noticed the error. Let's start this week with the huge news of the high-profile New England Journal of Medicine retraction. Like many stories on this podcast, I try to pick topics that have both specific and larger messages. When the New England Journal of Medicine retracted a 2018 paper on ambulatory blood pressure measurements, the news specifically affected how we think about blood pressure and mortality, but more generally and more importantly, the retractions informs how we think about the trustworthiness of traditional peer review. Let's start with the concluding sentence from the editorial at that time the paper was published. Quote, "The take-home message from this study is that ambulatory blood pressure monitoring is a valuable tool in the assessment of the most important and treatable factor worldwide contributing to premature death and disability, namely blood pressure." Well, no. The take-home message from this study, which has been cited 190 times, is that based on concerns raised by the senior authors, the data is not reliable. And so this study does not tell us the value of ambulatory blood pressure. Now, Medscape Vice President of Editorial and co-founder of Retraction Watch, Ivan Oransky, nicely lays out the details in his news recap. In short, because of a very short comment on PubPeer, think wisdom of the crowds, the authors identified inaccuracies in the database. First, they noted errors in the original data tables. That then prompted the team to undertake a review of the core data and the entire analysis with an independent statistical team. And that evaluation identified errors in the core database linking the ambulatory blood pressure data to mortality, and this had errors in the resultant data tables. The authors told the New England Journal of Medicine and recommended retraction due to unreliable data. The authors say they are working on a reanalysis. Okay. It wasn't weeks ago that I talked about New England Journal of Medicine and its peer reviewers missing the fact that Excel authors did not report a key secondary endpoint that they said they would report. And for the last 2 years, I've been telling patients that frequent blood pressure measures at home are better than point measurements in the office. Now, maybe that's true, but a lot of the idea behind this came from the paper. What's more, this retraction should dampen excitement over these digital tools that will soon record near continuous blood pressure. What will that do other than further medicalize millions of people? To be sure, if continuous blood pressure or ambulatory blood pressure is proven to be beneficial and useful, then I will adopt it. But the burden of proof is on those who aim to digitize more of our lives. Finally, and I think this is the key message, if a PubPeer comment, and a short one at that, can prompt discovery of irregularities that peer reviewers did not, well, that says a lot about traditional peer review. My friends, this isn't the Kentucky Medical Journal. This is the New England Journal of Medicine. They're supposed to be the most robust of all journals. Serious vetting, right? If basic errors get by the New England Journal, what chance do lesser journals have with peer review done for free by busy reviewers? This story reminds consumers of medical evidence to maintain a high level of skepticism of science. Not cynicism, just skepticism. And my gosh, this has to be Exhibit 1 in the case for independent analyses of raw data on any study that could change practice. Second topic, TAVR at 5 years. This week, New England published the 5-year results of the PARTNER 2A RCT of transcatheter aortic valve replacement, or TAVR, versus surgical aortic valve replacement, SAVR. Recall that PARTNER 2A enrolled about 2,000 patients with intermediate surgical risk who had severe and symptomatic aortic stenosis. The mean age of these patients in the trial was 81 years. Now, a couple important facts about the trial were that slightly more than 1 in 5 patients in the TAVR arm had their valve replacement via a through-the-chest approach rather than up through the leg. The transthoracic approach is now known to be inferior than the transfemoral. So this biases the results against TAVR right off the bat. Now, another bias against TAVR in this trial were that the current iterations of the TAVR sapien valve perform better than those that were used in the trial. This is typical of device trials. And also, back in the trial, CT scans were not used for defining the valve type and for measurements. CT scans are now typical. So at 5 years, the death or stroke rate was 47.9% in TAVR, 43.4% for surgery. So the 4.5% higher rate of death or stroke in the TAVR arm did not reach statistical significance, but more on that in a second. The authors split up the results by type of TAVR, and it was clear that the through-the-chest technique does worse than surgery, but the group done via transfemoral, the primary endpoints were similar. When this study was presented at the EACTS meeting, which I discussed in a previous podcast, the presenter showed these things called landmark analyses. This is where you look at outcomes during the early and late period, and it's important in this particular instance because the trial outcomes change over time. The technical term we give to this are conditions of proportional hazards were not met, meaning simply early on TAVR does slightly better than SAVR, but then the curves switch, and if you look from 12 months to 5 years, the curves diverge and clearly favor surgery. From year 1 to 5, TAVR was 27% worse than SAVR for stroke or death. And this was significant as the lower bound of that hazard ratio went to 1.06. Also, when you look at the Kaplan-Meier curves, it's widening over time, meaning the longer you go, the better SAVR looks relative to TAVR. At 5 years, more patients in the TAVR group than in the surgery group had at least mild paravalvular aortic regurgitation. Now, the authors downplay both the landmark analysis and the AI issues, citing the iterative improvements in the current valves and also better sizing techniques now. One of the key limitations of this study, though, and it's really important, is missing data. Approximately 10% of the TAVR group were lost to follow-up versus 20% in the SAVR arm. At the EACTS meeting, statistician Nick Fremantle pointed out that this was a massive problem for the internal validity of the trial. So the take-home is, I understand why patients love TAVR. Our coordinator told me that many patients referred to the valve team, they already want the TAVR even before they hear any of the opinions or options. And this is where we, the cardiology community, have to be careful. Yes, the TAVR valve is better now, for sure. So is sizing, but the widening Kaplan-Meier curves over time in PARTNER 2A are worrisome. The differential and massive loss to follow-up should also decrease our confidence in the data. Yet I don't sense much lack of confidence amongst TAVR proponents. Well, keep in mind that the 2 low-risk studies are super short-term. And when we do TAVR in patients in their 80s, long-term data are less relevant, I understand. But as this technique goes to lower risk in younger patients, performance at 5 to 10 years is highly relevant. Being wrong about this could be a huge mistake. Third topic, targeting ICD therapy. Now, a commenter on a news story about ICD therapy remarked that we are using too many ICDs. His argument is that the vast majority of his patients who have ICDs never get a shock. Now, I'm not going into the overuse issue, but let's just set out that the observation that most patients who get an ICD did not need it is, in fact, true. Now, there's a good analogy for how primary prevention ICDs got established. Imagine giving antibiotics to everyone who came in with a red and sore throat. Now, you would cover all the cases of strep, but you would also overtreat the patients with viral pharyngitis. Of course, we now have a rapid strep test to identify only those who would benefit from the antibiotics. Similarly, ICDs were shown beneficial in large swaths of patients with low ejection fraction. But there is no rapid strep test of cardiology to tell us which one of those low EF patients will need protection against sudden deaths. As I tell patients, about 1 in 15 patients will have their life saved by an ICD, but we can't know who the one is and who the other 14 are. Now, of course, industry has no incentive to find a risk stratifying tool because that would mean fewer devices. Note, this is not cynical, it's just a fact. So that is why I was drawn to an interesting paper in the American Heart Journal from the Danish investigators on the use of focal scarring on MRI scans, focal scars to pinpoint patients who may benefit more from the ICD. Recall that the Danish trial was a large RCT in patients with heart failure due to non-ischemic causes that compared ICD plus contemporary heart failure care to contemporary heart failure care alone. Provocatively, that trial showed that the ICD reduced sudden death. It worked as it's supposed to, but it did not reduce overall mortality. So the study in the American Heart Journal was an observational sub-study within the Danish trial that took advantage of the fact that 252 patients in the trial of about 1,100 had had an MRI scan. The question was, does the presence of late gadolinium enhancement, or SCAR, identify patients who garner ICD benefit? Of the 252 patients who had scans, about half had SCAR. 50 patients of the 252 died. So the authors found that SCAR was an independent predictor of all-cause mortality, 82% higher, and this was after adjustment for known cardiovascular risk factors. But the ICD did not affect all-cause mortality for either patients with SCAR or patients without SCAR. The P for interaction was not even close. Now, what's provocative about this small observational study is that it goes against many other previous observational studies that showed that there was an association between SCAR on MRI and higher risk of ventricular arrhythmias and ICD benefits. In fact, a 2018 paper from an Australian group, Gutman et al., has reported that ICD benefit in non-ischemic cardiomyopathy was observed only in patients with LV SCAR. So we have to talk some limitations. Initially, I read this study too quickly when it came out, and I mistakenly thought it was a sub-study of an RCT, thus giving it more weight than an observational trial. But since the MRI scan was not randomized, this is a purely observational study, and what's more, it's only 252 of 1,100 patients. There certainly may not be enough power to detect a difference in mortality. So ultimately, you wonder, to answer this question, we need an RCT. And the authors tell us in the discussion section that this is planned. It's called the CMR Guide Study, and it will randomize patients with non-ischemic cardiomyopathy and SCAR to either an ICD or a loop recorder. Now that will be a fair test. Fourth topic is long QT syndrome. It is said often that much of what we learn in medical school is wrong. Well, friends, a report in circulation from a group of genetic researchers teaches us that there is a bunch to unlearn about long QT syndrome. Yes, another medical reversal is upon us. When I studied for boards a number of years ago, I was stunned to learn that there were now many forms of long QT syndrome. It wasn't just long QT 1 through 3 when I went to school. Now there was like long QT 4 through 12. Well, this study from a genetic consortium went back to the actual evidence and found that more than half the genes that are anointed as causing long QT syndrome have limited or disputed evidence. Only the 3 genes that we have long known, KCNQ1, KCNH2, and SCN5A, had definitive evidence as a genetic cause. Yes, there were some other genes that had strong evidence for causing rare kinds of pediatric long QT, but for adult cardiologists, the list of 17 putative genes that you see on these typical gene tests should probably only include the 3 well-known variants. Now, you should also know that this same consortium shot down all but one of 21 genes reported to cause Brugada syndrome back in 2018. Let me quote Dr. Michael Ackerman, who's a guru in genomic cardiology. Quote, "We're really in a phase of needing to do a tremendous amount of cleanup work in genomic medicine in general and in genetic cardiology. Because what we used to implicate a gene as a disease-causative gene a decade ago now in the lens of current knowledge and current data set, looks to be almost prehistoric. Now, why is this study important? Again, there are specific and expansive reasons. The specific reason is that many of the common gene panels list numerous genes that could be disease-causing. If a patient is positive for one of these, you could wrongly diagnose that person with a genetic disease. This could lead to overdiagnosis of family members if cascade screening is done. These new findings further strengthen the idea that phenotype must be the driving reason to do gene testing. Always have a good reason to do gene test. The expansive view of this study speaks to the precision medicine movement at large. As Dr. Dan Roden from Vanderbilt wrote in the editorial in 2018 on the Brugada syndrome paper, quote, "The revelations in LongQT and Brugada highlight the complexity of deploying genetic testing of any type in a routine clinical environment. Indeed, genetic screening in the absence of a phenotype is a fool's errand." Okay, I would add that remember, these are the simplest conditions to deal with genetically. They are single gene diseases. Consider that atherosclerotic heart disease or diabetes, obesity, cancer. These are polygenetic. Cracking the genetic basis of disease caused by many genes is going to be significantly harder. Now, I love medical reversals because they remind us how little we know, and thus they bolster the conservative approach to medical practice. Finally, screening for disease. A quick note on an important study outside of cardiology. I mention it because it informs the debate about screening for AFib or screening for vascular disease. The Nelson trial randomized 13,000 smokers to CT scan screening over 5 years in an attempt to show that this would reduce death from lung cancer, and of course, doing that should reduce overall death. Note that the Nelson trial used the best case scenario for screening. They did not use general population. They took those at risk for lung cancer because of smoking. Consider also that lung cancer is a deadly disease, and finding it early should help reduce death because you can cut it out surgically. One group got screened, the other group did not. A good study. After 10 years, there was a tiny reduction in death from lung cancer. Of 10,000 people screened, 8 lung cancer deaths were avoided. That's less than 1 person in 1,000. But crucially, this did not reduce overall mortality. All-cause mortality at 10 years of follow-up was nearly identical. What's more, the excess incidence of overdiagnosis rate was 19.7%. So the Nelson trial makes a cardiology podcast because lung cancer screening represents a best-case scenario for screening. It's low-hanging fruit. High-risk people, deadly disease, early detection would allow surgical removal, but no, it did not work. So, my friends, if you cannot extend the life of high-risk people by early detection of lung cancer, how are you going to extend the life by screening for something far less deadly like AFib or far more slow-growing like atherosclerotic vascular disease? I close this week by reiterating my contention that medical care is most pure when we treat people who come to us for help because of a problem. Before we intervene in people who are not asking for our help, the asymptomatic, we should have strong RCT level evidence that doing so helps. Thus far, the evidence for that is sparse. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing, telling a friend, giving us a rating. It really helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.